Good afternoon, everyone. We'll be getting started shortly. Good afternoon, everyone. Thank you so much for joining us today and spending your lunch hour with us. I would like to request that everyone mutes their line. I don't want to do a manual mute of everyone in case you do have a question. So if you could please mute your line, that would be greatly appreciated. Perfect. So today we're going to be talking about value and volume, establishing how much volume you are providing from a service standpoint, and really talking about value and what value you bring from an organizational standpoint. And sometimes we really have to overstate that to health plans so that they understand the true value that you all bring. One of the awesome things about Colorado is that Colorado is really a model for the country because of the hard work of organizations and agencies that you all work with. And so I want to say that I think that you all have done a great job, and this process only adds value to communicating that value to health plans. Our training webinars will be today from 12 to 1, and then next Monday from 12 to 1 will be our final training webinar. All webinars are located at our rtwelter.com/public health page. When you go to rtwelter.com, you'll need to select the coding tab, and then from there, there is a public health tab. And when you click on that public health tab, excuse me, and scroll down that page, you'll see 3 tabs with our billing and coding manual, some other resources, and then the webinars tab will have all of our cost analysis, rate setting, trainings that we're doing for the 2018 cost setting, cost analysis project. Today we're going to talk about volume and value, and really determining the value of everything you do from a financial standpoint. We're going to discuss how to multiply the value by the volume using various models. We're going to discuss the Medicare Fee Schedule, how to access that data, and how to actually apply that when you're determining your cost analysis and developing your sliding fees. We will also be looking at the logic for RBRVS, which is another model that you can use to conduct your cost analysis activity. We'll also be talking a little bit about the JSI focused cost analysis model. They have some great resources that I think everyone should be aware of, and maybe you've seen these resources, but I would like to walk you through those, as I want to remind everyone you are very flexible in the method that you use for cost analysis, cost setting. CDPHE and RT Welter have partnered together, and we want to make sure that this is as smooth of a process as possible. I know many of you have been through this process in years past, so hopefully you feel well prepared as you're tackling the 2018 cost analysis, cost setting. Performing a cost analysis activity is a Title X requirement, and essentially that's used to demonstrate how sliding fee scales are developed. As the OPA states, charges must be based on a cost analysis of all services provided by the project. So these webinars and tools that we've developed are designed to assist family planning programs in assessing the cost of providing clinical services. This allows programs to set appropriate fees to recover the reasonable cost of the services they provide. This information is also useful in negotiations with third-party payers regarding appropriate reimbursement for services. Every successful business knows the importance of understanding all the costs involved in providing their product. Family planning programs are offering services in an era of escalating costs and shrinking federal and state support, as well as increased competition. To survive, it is essential for family planning programs to implement strong business practices. This includes the collection and analysis of financial information that will provide insight to the real and complete costs of doing business. Only agencies with a sound financial management plan and a complete knowledge of the cost of doing business will remain financially viable. And this becomes increasingly important as the United States continues to implement health care reform as well as payment reform. Your cost analysis will allow you to understand the costs associated with your services, as well as make informed decisions about setting appropriate fees for your services. And our next training will really hone in on how to take this information and negotiate payment and rates with health plans and payers. The overall goal of sustainability is what we're after. We want everyone to be around for a very long time, and cost setting is only an effort to further that sustainability. Just to recap on some things that we discussed in our last training was all about focusing on costs and really identifying all costs associated with family planning and Title X services. So if you are part of an agency that provides other programs or services, you'll really need to hone in on what are expenses specific to family planning and Title X. Talked about categorizing costs into defined cost categories. I want to remind you that the way that we describe the cost categories and the examples that we provide are purely examples. So if those models or examples don't exactly fit your scenario, you are free to utilize whatever method or cost categories are most applicable to your setting. I know there was a question in our previous webinar regarding categorizing staff versus personnel versus provider-specific costs, and it's all going to depend on your agency, organization, and how you're structured. So you really have a lot of flexibility with regards to how you categorize your expenses and cost categories. Two large examples we discussed or operating expenses and personnel expenses. We also discussed separating expenses by program, and again, only accounting for family planning Title X costs. And that is done via a variety of methods, but using estimations is acceptable if you have employees or shared expenses across multiple programs. You can utilize estimates on how you determine the cost for family planning. You'll just need to be able to explain the logic behind the estimation. We also provided a really nice full-time employee time study to understand how to drive into how much time is spent on each activity based on each employee or staff member. So I encourage you to utilize those resources to identify all of your costs related to family planning and Title X. The most important thing to keep in mind when you are determining costs is to record your methodology, and any rationale or estimates that you're using have to be able to be described in detail as to how you came up with those figures. We also discussed sample cost analysis spreadsheet, which will be distributed later in the month after our trainings. You are more than welcome to use this tool. You can also use your own tool, or you can tweak this tool to make it work for you. I know that we are working with agencies of all shapes and sizes, so if this does not work for you, we can make it work for you. So please do not feel obligated to this example. So the cost analysis that we looked at was a 50-50 distribution to family planning providers that are nurse practitioners. We looked at total income revenue for 2017 quarter 2 to give you an idea of revenue, and then we broke that down by each provider. And then because both of our providers are family planning full-time, we were able to take our expenses and create a 50-50 distribution based on those expenses. Unfortunately, it's not always going to be this simple and cut and dry if your providers are shared across multiple programs. And again, that's going to go back to your allocation of staff and really determining how much time are spent on different functions. We talked about an example for nurse practitioner who may not be providing medical functions at all times. Maybe the nurse practitioner provides support for the lab or the pharmacy or any kind of counseling clinic that you have, and perhaps acts as an administrator at different times. So we would want to make sure that this nurse practitioner's salary and all costs associated with the nurse practitioner are allocated into cost categories rather than taking 100% of that nurse practitioner's time and allocating it to the medical cost category. So that was just one example. Family planning CPT codes. So one of the first things you will want to do to determine your volume is get a list of all CPT codes that have been billed in your agency for the last 12 months. That's a good starting point. And basically your CPT code is going to be your 5-digit service code, which can describe anything from contraceptive management, a well woman visit, to an office visit. So once you're able to identify that list, you can then determine the non-facility RVU associated with that CPT code. So we've got our CPT codes, we've got our code description. This is not the full CPT description. This is a shortened version. And then we've got our non-facility, and we'll talk about what that means in just a minute, RVU, and then our conversion factor, our dollar value for Medicare Fee Schedule, which is $35.82. So we take that number, we multiply it by the RVU for non-facility, and that gets us our fee associated based on Medicare's fee schedule. So for example, a 99203 has a non-facility non-facility RVU of 3.02. We take that number, we multiply it by 3582, and that's how we get our Medicare reimbursement. You'll need to get that list, that comprehensive list of CPT codes your agency provides, and then you'll also need to obtain the non-facility RVU data, and you can also get that same data for the Medicare fee schedule. And we're going to talk about exactly how to do that in this webinar. Once we have our code information, so the list of CPT codes that we're rendering in our clinic or our agency for family planning, and we've got our non-facility RVUs and our Medicare fee schedule, then we actually have to take it a step further, and we want to look at our total yearly volume for each CPT code. So for example, we've got 99212. That has RVUs of 1.22 for a Medicare fee of $44.39. And then we've got our total volume for the year. It looks like that particular CPT code was billed 78 times in a year. So we take that number and we multiply it by our Medicare fee schedule rate, and that's how we come up with our estimated annual collections for revenue for that particular procedure or that service. That information can also help us determine our total RVU for that particular procedure or service. So we're taking 1.22 for our non-facility RVU, we're multiplying it times 78, which is our volume, and that is going to give us our total RVUs for 2018. This is just an example. Yours may not look like this, and that's totally fine. Again, these are examples for training purposes. Much of your CPT distribution is going to fall into the evaluation and management category, but there will be other categories that you will account expenses for. For example, some of your procedures. So many of the visit types for family planning fall into the E&M, for Evaluation and Management Services section. These E&M codes focus on visits by new and established patients, and for family planning providers will include anything from 99201 to 99205 for new patients, and then 99211 to 99215 for established patients. In addition, programs may use preventive medicine services or codes, and that will be these CPT codes 99381 to 99397. And these are all based on age of the patient and whether they're new or established. Other visit types will fall under procedural services. So instead of the CPT code starting with a 9,000, you'll be looking at CPT codes for procedures and contraceptives, IUD insertions, IUD removals, Implanon, Nexplanon, depots. These are going to be in a variety of different chapters in your CPT manual. If you have a practice management system or electronic health record that allows you to produce these reports, it will make your life much easier, and this will become a much less manual process. If you do not have access to these resources, perhaps there's another way for you to identify your CPT codes by volume, but you will need this information to conduct your cost-setting activities. Site of service. So this is just some background information for you so that you understand exactly what these terms mean when you're identifying your non-facility RVUs. So facility is defined as a service provided in a facility setting, such as a hospital, nursing home, a surgery center. These are not going to apply to you. The expense RVU is lower for facility because they don't have to account for overhead, staff, equipment, or supplies used to provide the service. So when you do get your Medicare Fee Schedule and your RVU list, you'll notice there are categories for both facility and non-facility, and it is imperative that you're selecting the non-facility RVU Medicare Fee Schedule data. These are services performed in the office, which again will be your setting. Higher rates, you'll notice that the non-facility RVU, non-facility reimbursement is higher due to overhead expense. So they're accounting for equipment, staff, space, all of the things that have to be accounted for when determining reimbursement. Make sure that when you are billing your claims insurance, you are selecting the correct site of service on your claim form, your HCFA, which is site of service, place of service 11, box 24B. If you all could mute your lines, I would greatly appreciate it. I'm hearing some background noise. I do see that there is somebody that is having trouble hearing us. Can I get someone to type in the chat box that they can hear me okay? Okay, thanks, Jody. Nancy, you may need to log off and go ahead and log back in or dial into the number. RBRVS. So this is the information that I told you guys earlier we were going to drill into. This system was created in 1992 by Medicare, and it stands for Resource-Based Relative Value Scale. And this was created and developed to standardize physician payment schedule based on the cost to provide the actual service. Each CDP code has a set relative value. A relative value is a number that relates to one service to all other services based on the amount of time, materials, and level of skill of the personnel involved in the particular service. Relative values indicate how much one procedure is worth in relation to another procedure. Each relative value is important only in how it compares to other relative values. This payment system is used by CMS as well as the majority of other insurance payers. This system is based on the principle that payments for services should vary based on the resource cost for providing those services, and is intended to improve and stabilize the payment system while providing or allowing providers an avenue to continuously improve the system. There are three main components to the RBRVS system: work, expense, and PLI, which is professional liability insurance. Work is, physician work is 51%, expense is 45% of the cost, and then 4% for PLI. So that's just a very basic overview of how the components are determined and how they're factoring in the resources that are required to provide the service. Payments are then calculated by multiplying the combined cost of a service times the conversion factor, which is a monetary amount determined by CMS and adjusted for geographical differences in resource costs. So payment is then calculated based on relative value, GPCI, which is geographic practice cost indexes, and then that's multiplied by the conversion factor that's set by Medicare every year. Commercial health plans work off of a fixed fee schedule, which is usually roughly based on Medicare's fee schedule. So you'll see some commercial health plans reimburse at 120% of Medicare fee schedule. That's just an example. The RBRVS is updated annually to reflect new and revised CPT codes. Every year they update the RVRVS manual, so you'll want to make sure that you're using the most up-to-date values. Medicare fee schedule. So this is a complete listing of the maximum amount Medicare will pay a provider or supplier for a fee based on the service that's provided. So it's fee-for-service model. CMS develops fee schedules annually for everything, for providers, for ambulance services, lab services, any kind of DME or prosthetics, orthotics, medical supplies. There are a variety of fee schedules. And when you pull your fee schedule information, you may have to pull multiple fee schedules depending on the services that your organization provides. These are updated and changed annually, like the RBRVS system. So make sure that you have the most current data. Medicare allows a certain amount for each service. So best practice is to make sure that you are billing higher than what is actually going to be paid, sometimes 2.5 times what the allowed fee is. The comprehensive listing of fee maximums is used for Medicare fee schedule to reimburse a provider on a fee-for-service basis. So the idea is the more volume, the higher the reimbursement based on the volume. CMS develops fee schedules for everyone, as I said, and you guys are no exception to that. So your fees will be described in the Medicare fee schedule. Keep in mind that Medicare family planning codes differ from Medicaid and other payers. Sometimes Medicare has their own special G codes or Q codes for services, and these will differ from the CPT codes that you're using for commercial insurance plans. So just keep that in mind when you are identifying your fees and your services. The codes may not be a one-to-one match. Where can you obtain this data? The data is on the CMS website, cms.gov/Medicare fee schedule. And I will warn you, this is a screenshot. The downloads, there's like probably 20 different files for download. So you want to be really careful that you're picking the correct fee schedule that's for this year as well as for the services that you're providing. Code values. So determining the value of the services you provide. RVRVS is trending upward each year. Now, the system as a whole stays neutral. There's no increase in the overall RBRVS. But what they are doing is taking RBRVS or RVUs from other CPT codes or other specialties to offset some of the costs with evaluation and management services. So recently, we have seen a shift where we're seeing higher RVU attachment to evaluation management services, E&M services. That is a really good thing for you guys because that's bulk in the majority of what you do and what you provide outside of your procedures. Make sure that your contracts and the payers that you're contracted with are utilizing the most recent version of RBRVS or Medicare Fee Schedule. Todd does this every day, all day. This is his wheelhouse. But, you know, we were just talking about an example where he was looking at a contract and the data was based on 2006 RBRVS data. That is a long time ago and obviously very out of date. So the devil is in the details as far as this kind of stuff, and you want to make sure that payers and your contracts are up to date and based on the most recent version of this data. Changes are and updates are made annually. So again, if you do this one time, you're not done because it updates every single year based on a variety of factors. So we talked a little bit about volume earlier, and I showed you guys an example that looks very similar to this. But now we're going to actually drill down into this a little bit further. So we have our CPT codes, we have our CPT code descriptions, we have our non-facility RVUs, our Medicare fee schedule for each particular allowed charge, and then we have our production by nurse practitioner by week with total calculations by week, and then we're taking that to determine our average monthly volume based on 3.5, and that's going to get us our estimated monthly revenue. So when I talked about using estimations earlier, this is where you want to make sure your logic and your rationale for estimation is documented. You do not have to break this down by week. You can do this by month or however you see is the best way to come up with the same final answer, which is estimated monthly revenue or estimated yearly revenue, depending on how you're going to break out your cost analysis. So for 99214, which is an established patient higher level visit, we've got RVU of 3.01 and our Medicare allowed fee schedule for $107.83. We're looking at a per week basis, and we've got both our nurse practitioners rendering 15 99214s each. Excuse me. So that's a total of 30 99214s per week. And we're doing a 3.5 conversion, so that's a total of 35 per month. And that gives us our estimated monthly revenue for the service, which is just shy of $1,600. So, I'm sorry, 99214, $11,321. I apologize, I was looking at the wrong category. So that gives you a breakdown by CPT code of the revenue anticipated for that particular service. You'll need to do this calculation for every single CPT code that has volume for your agency. And then we get further into determining the value. Value is a subjective and very relative term, but we're really taking the data that you have and stating, okay, we provide this many services per week, per month, per year, and our value is determined based on a variety of factors, but our volume is what helps support the value. So when we were looking at our 99214 example, that's going to account for a large portion, actually the largest portion of our estimated monthly revenue based on these lists of CPT codes. So that is a really nice overview of drilling into how to identify your volume and your value from a reimbursement standpoint. It may not be exact figures, but it should be pretty close if you're using recent data. I also want to talk a little bit about the JSI Focused Cost Analysis resource that is available to you all. I believe through the NTC, the Family Planning National Training Center resources. If you have access to this, I encourage you to utilize these if it works and is most appropriate for your setting. These resources are amazing. They are so well thought out and put together. So I have to give credit where credit is due, and I do think that this model is a very reasonable option. And again, it kind of takes the guessing out of it because they've really drilled down into each step and how to take it from nothing to a full utilization data report, full cost analysis, cost setting activity. So the model is essentially utilizing either a cost report or cost pool calculation, and then looking at your procedures to RVU conversion, and then the utilization data report. So looking at how many times you've provided this service and what does that look like from a revenue standpoint after all of the figures have been calculated. Again, this is a screenshot of some data that we had access to from the JSI FCA model. But this spreadsheet is the cost report spreadsheet, and this is used to document family planning costs in the agency. So the cost categories are a little bit different than the training example that we reviewed, but the cost categories are administrative. So this is, policy, project management, procedure development, training, patient transportation, if you provide any transportation services to clients, medical. This is hands-on medical services by providers and nurses and delivering family planning methods to patients. This can also include history, physical exam, laboratory costs, pharmacy costs, other health services like outreach, education, specialized counseling. There's also a pretty extensive other category, which again is really accounting for any cost that hasn't already been accounted for in a cost category. Employee health, this will include fringe benefits, FICA tax, work comp, unemployment insurance, pension, and then facility costs. These are related to the purchase, rent, and maintenance of your facility, and could include things like housekeeping, maintenance, rent, mortgage payments, utilities, again, anything related to running the facility. You're welcome to utilize this report. Again, it's going to be broken down by those categories that I've mentioned, and then you're looking at categories for agency costs, direct family planning costs, indirect family planning costs, in-kind contributions, again, specific to family planning, to determine the family planning costs for each category. We talked in our previous webinar about direct costs, indirect costs, and in-kind contributions. So if you missed that training, I would encourage you to go back and review our webinar one. Cost pool calculation. So this is essentially the section that's going to help orient the cost report that we just talked about. And this is really taking total expenses after you've drilled into your costs and eliminating anything that is not able to be accounted for. So things like fundraising or lobbying, agency expenditures that have to be deducted, restricted expenses, things that are related to grant funding, unallowable expenses, referral visits, procedures, or expenses not to be charged to patients or third parties. Again, this gets very technical. If this stuff does not apply to you, that's fine. I did leave some figures in here for you guys just to see what that looks like once it's kind of all filled out. And then the procedures to RVU conversion. So this is very similar to what we discussed earlier in previous slides with regards to getting that comprehensive list of CPT codes that identify the services that your clinic provides specific to family planning. So it looks like we've got our LARCs, we've got, it looks like some destruction, IUDs, all of this stuff will have to be related to family planning. So if it's not related, it cannot be used for this calculation. So we've got our CPT codes, our service description, we've got our work RVU, our overhead RVU, our malpractice RVU, which again are just different terms for what we discussed as far as what's used to calculate the overall reimbursement for our total RVU for each service. We've also got our GPCI calculation and indexes, and then that will help us equate our total adjusted RVU. This model is a little more technical and a little more robust than the model that we have used in our training examples. I think that this is great if it works for you, but I don't want you to feel obligated to this because you are flexible in whatever method you decide to use for your cost-setting activity. And then we take it a step further and we look at our utilization data. So in our previous slide, we were really looking at procedures to RVUs. Now we're looking at utilization and frequency, and then that information and data and calculating it by a variety of factors. And we're looking at average cost, adjusted total cost, service cost, maybe your current fee. If you have a COLA or cost of living adjustment allowance, these do go up every year. So if you wanted to add a COLA adjustment, just make sure that you are explaining that and accounting for it in your rationale. So how do you use this information? This information can be used to negotiate with payers. So our commercial payers like United and Anthem, we can take our findings and we can give it to the payers when we're asking for higher reimbursement for our services to further justify the value that we bring to healthcare. You guys are amazing in what you do and the value that you bring and the statistics and the data that you have to support the value that you bring to the community. This information can also be used to develop your sliding fee scale. So when you're getting a good indication and a good picture of the cost of doing business, you're able to properly develop these fee schedules so that you're at least able to break even and cover the expenses of doing business. This information can also be used to analyze productivity of your providers, as well as adjusting staff and resources based on the overall goal of sustainability, and also to to ensure break even of our costs. I'm seeing a request to make me presenter. I'm actually getting ready to wrap up, Jennifer, and then I can definitely do that if you'd like to share something. So how to conduct a cost analysis. Allocate all expenses to the appropriate cost categories associated with the delivery of each service. So that's webinar 1 in a nutshell. We're taking all of our costs and figuring out how to allocate them to appropriate cost categories. Collect relative values for services family planning provides. So that's essentially what we discussed today regarding RBRVS, Medicare Fee Schedule, determining the value from a reimbursement standpoint for family planning specific services. Collect utilization data on all family planning services. Again, that's what we discussed today, taking a look at every single CPT code that is billed and provided so that we can look at utilization and calculate the overall cost for those services. And then determining the cost of each service and establishing fees based on this information. So once we identify utilization, cost, relative value, then we can look at making informed decisions about how to determine our fees. Some helpful reminders. So you may use any form of cost setting that is appropriate for your setting, so long as it can demonstrate how fees are determined on the sliding fee scale. So you must be able to provide this information and rationale behind how you came up with your fees. If your organization has recently updated its cost setting activity, it must have been done in the last 12 months to be considered valid for 2018 cost setting. So anything April 2017 forward can be used. Anything before that will not be acceptable. CDPHE is here to help you. We are also here to help you. Jody Camp, she's amazing. She's on the line. She is more than happy to help you guys with any questions you have related to cost setting. Her contact information is on this slide. For March, our timeline is such that we are doing our web-based trainings on cost setting, cost analysis. So today is our second webinar. We will have one more webinar next Monday. We will also be distributing cost setting templates as well as the cost setting summary uniform template. These will be distributed after our trainings. More than likely, Jody will be emailing these out to everyone. And I, again, want to remind you that the templates that we provide for the cost setting are not required. You do not have to use those if they are not appropriate for your setting. You are free to do whatever method is appropriate so long as you can explain your methodology. The cost setting summary uniform template is mandatory because it requires you to provide some supporting documentation on how you came up with your cost analysis. So this is what that sample cost analysis looks like that we'll be providing. It will not have any data in it, just the categories. And then the cost setting summary uniform template. These are the questions that you'll be required to answer in conjunction with submitting your cost analysis. So how did you carry your cost analysis process out? Was it done by a third party, and who was that third party? Was it done internally by your accounting department or by someone else? What period in your organization's fiscal year was used to determine your cost analysis? Was it your calendar year or fiscal year? Which reporting period did you use to base your cost analysis? Again, calendar, fiscal, or both. You'll need to be able to provide supporting documentation on itemized expenses included in your cost analysis and the annual cost for each item. You'll need to be able to explain the determination for value of services, whether you're using the methods that we discussed today, Medicare Fee Schedule, RBRVS, or other, which could be that JSI model or any model that you use, so long as you can explain how you came up with your cost analysis. Supporting documentation with a list of CPT codes to determine annual volume for each. Supporting documentation for your most recently approved sliding fee scale. If your organization did not conduct their cost analysis according to the methods reviewed in our training, please provide a summary description of the method your organization used. Again, it's just going back to explaining how you came up with the figures that you came up with and the methodology behind your cost analysis activity. Supporting documentation on any comments that could help further explain your cost analysis process. So this template will be distributed later in the month. It is mandatory that we have all of this information when you are providing your finished cost analysis. April. So you should be in the thick of cost setting, cost analysis in April. Please do not wait until the last minute to do this, because it will make your month seem very, very painful and long. RT Welter is available for technical assistance if you have questions or need some consultation or personalized coaching. We offer 30-minute consultations, and we are happy to help you or guide you and simplify this process in any way that we can so that you can be successful in your cost setting, cost analysis for your organization. I want to remind everybody, and I know that Jody will also remind you, we as RT Welter cannot conduct your cost analysis for you. You are responsible for doing that. We are more than happy to assist. CDPHE is more than happy to assist. We want to make this process as painless as possible, but you will have to do it. You are responsible for that. It is a Title 10 requirement. Your cost analysis is due to CDPHE by May 1st. Technical assistance, please reach out to us. You can reach out to both myself and Todd Welter. You may get a quicker response if you reach out to us via email. I've already got some questions from a few of you via email, and I appreciate your questions. You may also contact us via our office phone line, which is posted here. I highly encourage you, utilize your tools, utilize your resources. You are not being left to do this alone. You are being given many resources and tools to ensure success. Once more, cost analysis is due by May 1st. There is no wiggle room with regards to that deadline. It is a hard deadline and must be completed. During the month of May, RT Welter will review each cost analysis and provide necessary feedback. We may need to get in touch with you to ask questions or get additional information regarding your cost analysis. All cost setting activities and updated sliding fee scales must be completed, potentially edited and approved by May 31st. So it's imperative that you get us that cost analysis, a cost setting activity by May 1st, because we are going to need those 30 days to contact you, to get more information, to potentially edit and have you make some edits. So we have to work together to ensure that we're meeting this deadline, as it's a contracted act with OPA and Title 10 must be completed this fiscal year. Next week, we'll be talking about how to take all of the information that we've learned and put it together in order to develop your fee schedule and understand how to take this information to utilize for negotiating purposes with health plans. At this time, I would be happy to take any questions that you have. So I'm going to go ahead and take a look at the chat box. It looks like we have a question from Nancy. I'm sorry that you had some technical difficulties, Nancy. Is the non-facility RVU the same as the physician fee schedule? So they're two different things. The RVUs are relative value units by CPT code, and the physician fee schedule is going to actually have a monetary value based on the information that's used to compute the RVU data for each CPT code. So they're actually two different things. But you'll be able to access that all on the CMS website. And I think, I'm not 100%, but I think it's all going to be in the same file. Feel free to unmute yourself if you'd prefer to ask your question by voice. Jennifer, I do see your comment about making me the presenter. If you could just let me know exactly what your goal is for doing that, and we can discuss any questions that you have, that would be really helpful. While I'm waiting for any other questions, I do want to remind you guys once more that this is being recorded and will be on our website probably in the next day. We already have webinar 1 up on our website if you missed it, or if you'd like to share that with anyone that missed it, or if you'd like to go back and reference it. Jody, I know you're on the line. Did you have anything that you wanted to add or say?
No, I just want to thank, this is Jody Camp. I'm the section manager of the Title 10 program at CDPHE. And I just want to thank our T. Welter & Associates for walking us through this webinar number 2. And anybody on the call, I'd ask you to review webinar number 1. Thank you for participating on this webinar number 2. And a third webinar, as Tony said, will be offered next week. I'd also encourage you, please, to share the information, not only with your fiscal staff, but with your program staff as well, so everybody's on the same page. Thank you.
Thank you, Jody. Thanks for that. That was great. All right, guys, well, if there are no other questions, I am going to end this now. Feel free to contact us if something comes up after the fact, or if you do have a question that maybe is more geared towards your agency. But I really appreciate your time and attention, and I thank you so much for spending your lunch hour with me.